Before I start, I just take the opportunity of having the microphone to say a personal thanks to Craig and Andy for their really great mentorship and support, and mentorship in a way that I think has helped me to become a good doctor and an independent thinker, and mentorship in a way that's sort of, I think, given me the confidence and freedom to kind of pursue some of my own ideas, whether good or bad, make mistakes and have some successes, and I really thank them for that. It's really been tremendous working with them. I'll also point out that as I go through my talk, if you look at the references, all on T-cell lymphoma, this is an area that Craig and Andy have not specifically worked very much themselves, but you'll see many of the references from people that they've mentored or co-mentored or had formative influence in the early parts of their careers as we go through. And I think that's really also a testament to them in terms of how their effects have been outside of their direct field. And they've really have affected the field in a much broader way through their personal qualities. So thank you. Okay. In terms of paradigms to move us past CHOP for newly diagnosed peripheral T-cell lymphomas, I'm going to kind of divide this into the past, present, and the future. The past is sort of understanding where CHOP doesn't work and finding different approaches, maximizing cytotoxic chemotherapy. That's the past research. It's kind of our current treatment paradigms. The present would be our current research studies, looking at some of the new drugs and some ways of combining those new drugs really on top of what's still a CHOP or a CHOP-like paradigm, and then touch briefly on the future and some of the more novel combinations and picking up on the theme of identifying different targets, individualizing treatments based on individual patients' tumors. So this is sort of the smaller world of peripheral T-cell lymphomas as distinct from the bigger world of all non-Hodgkin's lymphomas. There's a lot of different subtypes. I think probably for lack of understanding, maybe lack of creativity, lack of detailed information, we've more often treated them the same rather than different. And clearly, as our abilities increase in the future, that can't be the best way to go. The majority of the patients have one of the more common subtypes, peripheral T-cell lymphoma unspecified angioimmunoblastic, or one of the subtypes of anaplastic large cell lymphoma. And I think if we think of CHOP or CHOP-like treatments as a paradigm that we want to either improve upon or get away from, the initial understanding has been in the diseases where that doesn't work well. So if you look what we get with that CHOP paradigm or CHOP-like paradigm in terms of the T-cell lymphomas, we have this group of relatively more favorable ALK-positive anaplastic large cell lymphoma. So that's going to be 7 to 9% of your T-cell lymphomas. And those patients are more often than not, though I'd point out that the progression-free survival there is about 60%, are more often than not cured with CHOP or CHOP-like chemotherapy. If you just lump all the rest, we see that we're at most impacting maybe 20, 25% of patients long-term with those approaches. So clearly a lot of room for improvement. Some of our biggest improvements have been in rare subsets of disease, where we really just recognize that CHOP chemotherapy just doesn't cure anybody or really doesn't work, and these people need a fundamentally different approach. This is just one of the first reports of hepatosplenic T-cell lymphoma, and I'll just, by way of example, show these patients all got CHOP-like chemotherapy. DOD means dead of disease, and you can see that it really didn't provide much benefit to anyone long-term. A couple of patients with a different approach were alive. We, a number of years ago, then adopted a different paradigm, ICE or IVAC up front, moving away from anthracycline-based chemotherapy, trying to get those patients into first remission. And while our data is far from perfect, at least in our patients who've gone down that road with that approach, about half of our patients are long-term in remission. And we're continuing to see good responses and patients surviving with this different approach. I think another place where a fundamentally different approach really looks to be better, again, we're not in the realm of large randomized studies here yet, but in terms of NKT cell lymphoma. So this is just early stage disease, which I'll focus on. This is data from the Peking University Medical Center, where historically most patients have gotten radiation alone for early stage disease, some patients that got chemotherapy alone, and those are the survival curves or progression-free survival. Now, about 6 or 7 years ago, we sort of adopted a modification of this Japanese regimen called SMILE, which is a very dose-intense regimen. It includes an important drug, asparaginase. We modified a little bit with pegylated asparaginase, changed the cycles a little bit. But with just giving 2 cycles of SMILE followed by radiation, again, our results, single institution, but our results at least look to us like this is a fundamentally better way to approach this disease. And certainly a CHOP paradigm is something that has not benefited many patients with this disease. In terms of the rest or the bulk or the more common patients where we're really still locked into a CHOP-like approach, I think the most modifications have been done on that is just sort of maximizing the chemotherapy, which I would say is sort of the past approach, but presently how we manage most of our patients. So there's some subset analysis from some German studies looking at the addition of etoposide to CHOP for aggressive lymphomas in general. These are the T-cell patients here. The caveats are these patients are the younger group, not the older group, and most of these patients had anaplastic large cell lymphoma, even though statistically that shouldn't be the case. But it looks like if you add etoposide, maybe you do a little better, maybe a little more CR, maybe more patients event-free at 4 and 5 years. And then if you further maximize that approach by consolidating with autologous stem cell transplant, this is, again, a phase 2 study by intent to treat, CHOP etoposide, followed by autologous stem cell transplant. We get the progression-free survival up to about 40 or 45%. And I think if we sort of max out the CHOP-like approach, I think that's about the best we can do. And I'm not optimistic that we can build a lot just giving more intensive chemotherapy. We're able to refine a little bit who we think is most likely to benefit from that approach. And in T-cell lymphoma, though we don't have the data sets that we have in Hodgkin's disease, it looks like interim PET may be prognostic and may help in terms of guiding who should go to transplant and who would benefit from that upfront approach. My understanding is there's 3 abstracts at ASH discussing this, including an update of our series on about 100 patients. And basically, if you just look at the numbers, if you achieve an interim CR, and at our institution, that's been cycle 4, with an etoposide-containing chemotherapy and then go on to auto transplant. The majority of those patients, that's a small majority, but is the majority, stay long-term in remission. And the patients who are not chemosensitive rarely benefit from continuing on this intensified chemotherapy approach. And more we're looking to take those patients down a different therapeutic path. In terms of the present, as you all probably know, the advances in T-cell lymphoma have been modest, but there are some. We now have 4 drugs approved for peripheral T-cell lymphoma. I think when you look at this data, this is just based on the common subtypes, the approved drugs, and these are just overall response rates. Most of those numbers are more of the same in the 20 to 30 range. There's a couple of outliers. It looks like pralatrexate in small numbers may have a lower response rate in angioimmunoblastic T-cell lymphoma, which we now know is a different cell of origin, a follicular helper T-cell. And of course, brentuximab vedotin has much higher responses in anaplastic large cell lymphoma where it's approved. And those are the universally strong CD30 expressing lymphomas. In terms of how to build on the activity of new drugs, so the first attempts, which are ongoing, and some of them are nearly completed, have really been to build new drugs onto a CHOP backbone or a CHOP platform. So this is data, a phase 1 and then expanded cohort study combining brentuximab vedotin to CHP. The O or the vincristine was dropped for some concerns about overlapping neurotoxicity and not a lot of enthusiasm that vincristine was a critical drug in T-cell lymphoma. In small numbers, the response rate was high, mostly anaplastic large cell lymphoma. All patients responded to this drug in combination with chemotherapy, most of them completely. None of these patients got consolidated with transplant, and again, with all the caveats of a small study, the progression-free survival curves updated at 3 years look like they might be better than what we would expect with CHOP alone, and the overall survival there, for whatever it's worth, is really outstanding for that group of patients. This came up earlier in terms of CD30 negativity, or does CD30 predict? I think in T-cell lymphomas, we've seen the same thing, that there's been good responses in people with low levels of CD30, including some patients that may have had CD30 negative status. So I'd say in the T-cell lymphoma, the CD30 negative patients are a little more suspect that they're truly negative. The best analysis we have in that setting is in mycosis fungoides, so a little bit of a different disease. This is cutaneous T-cell lymphoma. This is a study we worked on with the Stanford group that they really led. Patients down here had high responses. This is a reduction in their skin. This is your degree of CD30 expression, and anybody in blue is a responder. So if you look, the patients kind of cluster down here, but there are responses in relatively low CD30 expression. This was done in a fairly rigorous way where every patient had multiple biopsies, and each biopsy had multiple cuts, and the CD30 max was reported of your multiple cuts on your multiple biopsies. And it looked like that if you had a biopsy that was 5% or above, your response rate was about 83%. So this is small institution data. There's a large randomized study which will be reported at ASH that in a 10% cut point also recapitulates a high response rate. But if you had very low CD30 expression, the response rate dropped quite a bit. And I think Jonathan's point was excellent, that if you think you have to respond to ibrutinib to benefit from ibrutinib plus R-CHOP, it may be that if you're a good responder to brentuximab, it's not so hard to imagine that adding brentuximab to a combination chemotherapy regimen will benefit those patients. Hopefully we'll have data on this soon. This is something called the Echelon-2 study, which is a large, more than 400-patient multi-center study taking patients with newly diagnosed peripheral T-cell lymphoma. Many anaplastic large cell lymphoma patients or the other subtypes have to have 10% CD30 expression and randomizing them to BV plus CHP versus placebo plus CHOP. The study is almost accrued. I don't know how long it's going to take a readout in terms of events, but we know in T-cell lymphoma that events of progression tend to happen quickly. So we may have data within a year or so on this study. Similar attempts are being made with some of the other new drugs. So romidepsin was added to CHOP in a phase 1/2 study, and once the dosing and schedule were worked out, again, it looks like maybe a higher complete response rate than you would expect with CHOP alone, and maybe the short-term progression-free survival is better than what you would expect with CHOP alone. And in Europe, a very similar strategy, primarily in Europe, is being done, adding romidepsin to CHOP, this time in unselected patients with T-cell lymphoma. So we may get a sense from that study, and that study may be large enough that we'll be able to tell whether all or perhaps certain subsets benefit from the addition of an HDAC inhibitor, but that study I think is still a few years away. Lenalidomide, which has been mentioned, does have activity in T-cell lymphomas. It's now on the NCCN guideline, though it's not approved for that indication. And the numbers when we look at unselected patients are kind of overall in the 20 to 30% range, maybe a little higher in the angioimmunoblastic patients, similar to what we've seen with some of the other drugs. So Matt Lunning, who's here today, who's a previous mentee of our honorees, is leading this as a T-cell consortium study looking at the incorporation of lenalidomide to CHOEP. It's done in a phase 1, then phase 2 fashion, and then we'll look primarily at a CR rate as an initial trigger in terms of endpoint. Again, thinking, as has been discussed, that if we can improve the CR rate, we have a chance of improving long-term survival. If we're looking at therapy with curative intent, if we can't get people into CR, we don't think they're going to be cured. So that's kind of where we are in terms of current investigations for the upfront setting. In terms of the future, I think we're hoping that a better understanding of these lymphomas is going to lead to better therapies and probably more tailored therapies. Our initial looks at that have mostly been in terms of combining active drugs without a lot of sort of molecular or predictive selection. So this is just one study that we recently finished, combining romidepsin, an active drug, with lenalidomide, an active drug. And the early readout is that the response rates were higher than what we would have expected with each drug alone. With each drug alone, we think the overall response rate is going to be about 25%. We got close to 60% in the T-cell lymphoma population. Probably too small to say that this is definitely an improvement. And with our goal of trying to define a better upfront regimen, too few CRs to think that this is a regimen that we would move forward into the upfront setting. But there's a follow-on study which is just enrolling its last patient today, I believe, combining carfilzomib or proteasome inhibition with this combination. So we'll have some data from that study updated at ASH this year. In terms of where do we go in terms of molecular targets, in the sense that can we be smarter and less empiric, and can we understand and individualize our treatment better? Well, there's a lot of interesting targets in T-cell lymphoma. A lot of them are similar targets, they're not all the same as what's already been discussed in B-cell lymphoma. We know that a fair percentage of a number of different subtypes of T-cell lymphoma will have activating mutations in the JAK-STAT pathway, and a much higher percentage will have evidence of pathway activation even without a specific mutation. Some of our collaborators and others have identified that in angioimmunoblastic T-cell lymphoma, or what's now being called T follicular helper-like T-cell lymphoma, that a subset of patients, about a third, have IDH2 mutations, and similar to what's seen in AML and MDS. And then again, to talk about other drugs or pathways we're interested in peripheral T-cell lymphoma, this is data from the University of Nebraska. We know that this pink curve here is a GATA3 population, and that population looks like it does a little worse, not quite as predictive as the ABC-GCB data, but that population is also enriched for signatures of PI3 kinase. So we're now part of a SCORE grant that's led by Dave Weinstock at Dana-Farber, and we have a growing clinical trial consortium to try to look at some of these questions and test some of these more novel therapies or targeted therapies in T-cell lymphoma. One of the backbones of that is a strong effort to get biopsies on patients, both in pre-treatment and at progression, and I'll show you how some of that is already informing our studies. And it's really working on that effort to try to understand how these targets are working, but also understanding that these single targeted agents are probably not going to be the answer, and that we'll have to build combination platforms. So this is just a case example of a first patient of ours with angioimmunoblastic T-cell lymphoma treated with an IDH2 inhibitor. So this is the first person on a study on a drug called AG221, which is an IDH2 inhibitor. Patient with relapsed angioimmunoblastic T-cell lymphoma, bulky lymph nodes of the neck, started him on this oral drug within 2 weeks. If you notice, all the disease we could feel went away. We got super excited, so excited that we said, let's get a PET scan so we can memorialize this moment with a photograph. And what we saw that is while those lymph nodes went away, he had progression of disease in the abdomen where we couldn't palpate. Andy Intelkofer has really led the IDH2 project for the SCORE grant, and with Ahmet and other collaborators in genomic have built a really interesting story. If you just look at this patient, and I probably will butcher the story, he was treated here where he had a subpopulation of cells were IDH2 positive. They've done single cell sequencing to try to tease this out. There's another larger population that is RHO-A positive but still retains a TET2 wild type, and a very small population that had lost TET2 wild type. With treatment with IDH2 inhibition, the IDH2 population went away. The RHO-A population, which is interested, even those that didn't have IDH2 mutation, decreased temporarily and then started to regrow. And the majority of what regrew at second biopsy is this, what was a very minor subpopulation that had no wild type TET2. And the question is this just heterogeneity of the disease? Is this how a tumor became resistant and got around the IDH2 mutation? I don't know, but I think the idea is that one example like this with one biopsy, so much has been learned of that this is the kind of technology that could really inform future trials or future combination strategies. A similar story that's less impressive in terms of the mutations, but perhaps was more relevant clinically to the patient. This is a patient with relapsed TPLL. This patient had standard treatment with alemtuzumab, ended up having an allo transplant to which he had remission for about a year, then progressed, treated with alemtuzumab again, then went on our romidepsin lenalidomide study, had a PR, reactivated CMV, and came off. His foundation medicine, as is common in this disease, showed a JAK3 mutation. He's treated here and across the street, so working with Giorgio Ingarami, who's one of our collaborators working on JAK-STAT pathway, was able to look at his cells. We were able to get him a JAK3 inhibitor called tofacitinib, which is used for RA. He had a very transient response, weeks to that, and then his cells immediately bounced back. If you can't read, this is 100,000 here, so this is a high white count. In the laboratory, looking at some of his cells, this should be ruxolitinib, not rituximab. Giorgio is a pathologist, so I forgive him mislabeling the graph, but this is ruxolitinib, and he looked at if you added additional JAK inhibition, you got a better result in terms of cell viability, and that resulted in a flattening of the growth of his PLL, and he actually maintained with disease control for about 9 months just on a combination JAK inhibition, and then eventually progressed. But it looks like in this patient that may have resulted in more effective therapy. So Alison Moskowitz is leading an effort again through the SCORE, a multi-center study, really trying to test this, and this will be one of our first looks at the JAK-STAT pathway in relapsed T-cell lymphoma. So this is a study of ruxolitinib where we'll divide patients into 3 groups. Each group will have a 2-stage phase 2 design. Group A will be the group that we think is most likely to benefit. Those are patients with documented activating mutations in JAK. There'll be Group B, which won't have mutations, but it'll have evidence of functional activation of the pathway. And then so we don't miss a signal, Group C will be unknown or unselected patients. And each of those will follow on in a 2-stage design with early stopping rules if there's lack of efficacy. Again, we think that these patients who respond may respond and then progress, and we're going to try to learn in what ways they're progressing. The last story, which I'll just wrap up with, is PI3 kinase. So we've worked with this drug called duvelisib, which in T-cell lymphomas had a response rate of 50% in peripheral T-cell lymphomas, about 30% in cutaneous T-cell lymphomas. This is a delta gamma inhibitor, including some of these outlier responses. These are a couple of patients in PTCL, one who's out actually almost 3 years now on continuing on the drug. There is some preclinical synergy with some of the other known active drugs in T-cell lymphoma. And that led to another study within our group looking at this drug in combination with romidepsin and with bortezomib, including a single agent PI3 kinase alone inhibition arm to try to collect biopsies to understand sort of who's responding and who's not, and when they progress, in what ways are they progressing. So this is the algorithm of our sort of clinical trial research group. We're going to really try to focus for relapsed patients on biomarker-informed or targeted therapy. For things like IDH2 mutation, that's going to be specifically targeted. For things like JAK-STAT or PI3 kinase, it's probably more targeting the pathway, and those studies are going to necessarily be a little less selected. We think with single agents, we may get some activity, but probably the story is going to be more complicated than that, and really look at biopsies on progression to really try to inform what would be further or secondary combination therapies. So I'll finish up there, just in terms of getting back to the topic of paradigms to move us past CHOP for newly diagnosed patients. I think we may be doing better than CHOP alone. I'm personally a believer in etoposide and auto transplant, but I think that probably moves the PFS curves up to about 40% or so, and I think that's about as high as they're going to go. We have a series of X plus CHOP study, new drug X plus CHOP. We're going to get a readout on those. Those are all going to be randomized studies, all powered for PFS, and within the next year to 3, we're going to know whether any of those strategies is truly a step forward, either overall or for certain subsets. I think short of one of those therapies fixing the problem, we're going to look heavily at some of the targets that we and others have identified and try to figure out ways to subset our population better and target them better. I didn't talk about immune checkpoint inhibitors. There's a little bit of data in T-cell lymphoma, but that story is still emerging, and I don't have a lot of data to show you, but there's some interesting things there. And then otherwise, I think the essential things about trying to make this better, I think it requires collaboration and really requires a strong bias towards enrolling patients on clinical trials, particularly with laboratory correlates to assess some of these endpoints. And our hope is that we'll come out of this in a better place with a better understanding of a lot of these therapies for our patients. And thank you. That's everybody. I'm just going to particularly call out Andy and Craig again, Allison, who's really like my co-partner in terms of a lot of these T-cell lymphoma studies. And just for the purpose of this group, give a plug to our clinical research staff. These multi-center, institutionally led IND studies are just really a burden on that group, and they've really done a fantastic job in allowing us to conduct these studies. Thank you.